Can you answer the questions correctly? Find out in this activity that is customized to you. Test your current knowledge with the series of questions related to the topic and rate your confidence for each answer. If you answered correctly and were confident, you will move on to the next question. If you need a little more information about the topic, an expert will provide evidence that supports the most appropriate answer choice. Then you will have the opportunity to try again with a similar scenario. When you have finished all of the questions, a summary page with your results will be provided, along with links to all of the expert presentations for your reference. Earn credit by answering the review questions at the end. Let's get started. The following podcast is part of a certified educational activity titled Adapting HIV Treatment for People with Substance Use Disorder. Access the entire activity and complete the post-test at peerview.com/VCQ860. Downloadable slides and practice aids are also available.
Today we're going to talk about adapting HIV treatment for people with substance use disorder. My name is Dr. Monica Gandhi. I'm a professor of medicine and the director of the Ward 86 HIV clinic at the University of California, San Francisco. And we welcome you to this activity exploring approaches for addressing the unique needs of people living with HIV and substance use disorder, the barriers they experience, and effective management for HIV. So in terms of the current state of the HIV care continuum in the United States, we're definitely not where we need to be. In 2021, for every 100 people living with HIV, actually only 66% are virologically suppressed. This rate of virologic suppression is lower than many countries around the world, and a lot of this speaks to some of the barriers we have to care and engagement in care in the US. One major barrier to both engagement in care and treatment outcomes is substance use. And the levels of substance use and dependence are higher among people living with HIV than the general population. This slide shows us that in terms of the past month use, looking at orange being the general population, blue lines being people living with HIV, that there's higher rates of alcohol or any substance use, including marijuana, cocaine, inhalants in those living with HIV versus the general population in the US. So because of that, we have to think about this as a risk factor for poorer outcomes in those living with HIV in the United States. And it really isn't just about poorer HIV outcomes, but also HIV transmission. Without virologic suppression, there are higher rates of HIV transmission. And actually, it looks like there are 35 times the risk of HIV transmission, forward transmission from people who inject drugs than those who do not. And this is data among different risk groups, but it's really the population that use drugs that you can see this vast disparity in terms of those who go on to transmit. That really speaks to lower rates of virologic suppression in that population, and thus optimizing treatment in those who use substances who are living with HIV will both have individual mortality and morbidity benefits and also benefit public health in terms of preventing forward transmission. Our goals for today are to enhance your recognition of unique barriers to effective HIV management for people impacted by substance use disorders to improve access to equitable care, to augment your skills for engaging patients in open, stigma-free dialogue about sexual health and substance use, to assess their risk of HIV transmission and solicit barriers to care, to expand your ability to develop HIV care plans that are guideline-based and patient-focused to support people impacted by substance use disorder in continuous treatment and risk reduction. And finally, to improve your skills in care coordination with mental health and substance use treatment providers to provide holistic care that considers barriers to care, continuity, and improves overall well-being. So, when we talk about all these social determinants of health that impact the HIV care continuum, let's first define the HIV care continuum. The first step in HIV management is, of course, to be diagnosed with HIV. Next step is to be linked in care, then engaged in care, then prescribed antiretroviral therapy, and then fundamentally the goal of care is to achieve virologic suppression for the individual living with HIV and staying retained in care. And in terms of this continuum, there can be slips at any point in the continuum that can be impacted by multiple determinants of health. So, what are the consequences of people living with HIV being out of care and not achieving all those goals on the care continuum? Well, it can not only lead to suboptimal antiretroviral treatment adherence, that can go on to ongoing virologic non suppression, which can lead to, of course, forward transmission. Viremia also, in the face of off and on adherence, can lead to the development of HIV antiretroviral resistance. And certainly for the individual not being controlled with HIV can get into lead to situations where there can be opportunistic infections or host immune disorders. So there are many consequences of being completely out of care. Now, substance use does increase the likelihood of behaviors that contribute both to being out of care and, as we discussed earlier, that will lead to viremia and contribute to HIV transmission. So, at this point, unprotected sex with an HIV serodiscordant partner among those who use inject drugs, there is a forward risk of transmission of 26% from males, 31% from females, and that's sex. And then if we look at the right side, syringe sharing, of course, is another risk factor for forward transmission from those who inject drugs who are living with HIV. And receptive syringe sharing is less risky than distributive syringe sharing, but all of these can lead to forward HIV transmission. In terms of further engaging in the HIV care continuum, how does substance use interact to work to disrupt care in those living with HIV? Well, drugs and alcohol weaken the immune system and worsen HIV progression. They can cause liver damage, certainly with alcohol. Some recreational drugs actually interact with HIV medications, increasing the risk of side effects. Drug and alcohol use can result in missed appointments and reduced treatment adherence, potentially resulting fundamentally and later on in antiviral resistance. And it can be overwhelming for the need of these overlapping services for those for HIV, for substance use disorder, and mental health treatment if those are not co-located. Having them all in one place can really help with engagement and care to have all those treatment services in a single place. So we do know that at each step in the HIV care continuum, substance use can prevent an individual from any of these steps. It can prevent getting tested from HIV, initiating ART, staying on ART, adhering on ART, and fundamentally, again, leading to HIV transmission in this face of ongoing viremia and consequences for the individual in terms of host immune responses and the risk of opportunistic infections. There are other social determinants of health that overlap with substance use that can also impact the continuity of care among people who inject drugs and have HIV. These other social determinants go hand in hand with substance use, and they can be having less than a high school education, having an income that's below the federal poverty level, being unemployed, being homeless, especially in the last 12 months, and being incarcerated in the last 12 months, and then also engaging in insurance or going in and out of insurance. So all of these are overlapping risk factors for people who inject drugs and who are at risk of or living with HIV for suboptimal prevention or treatment outcomes. So let's talk about stigma. And at this point, essentially, there are things that, of course, we can do in the healthcare provider setting to help mitigate stigma, which is one of the major barriers for people who inject drugs and people who are at risk of HIV coming into care. So the way that we can impact and destigmatize our provider-patient relationship is to be very matter of fact about who's at risk for HIV and the way that HIV is transmitted. HIV is transmitted through anal sex, vaginal sex. there's perinatal transmission, and sharing needles, syringes, or other drug equipment. HIV is not transmitted by kissing, by saliva transmission, by fomite transmission, from drinking from the same glass, and from casual activities. And it's important to give the risk factors for HIV and not in any way tell people that they should be concerned about risks about certain behaviors that do not transmit HIV. It's also important in a destigmatizing way to say that HIV can affect anyone, regardless of sexual orientation, race, ethnicity, gender, or age. And so to put sort of a broad risk category on everyone and not single out specific risk groups. The other thing that we can do to reduce stigma and bias elimination in the provider-patient relationship is to think about cultural awareness. Think and self-examine our own biases towards other cultures, gain cultural knowledge and a sound educational base about working with underrepresented minorities and culturally diverse groups. Figure out how to conduct a cultural assessment and a physical assessment in the context of working with diverse groups, engage in face-to-face cultural interactions, and be motivated to become more culturally knowledgeable and skillful. The other thing that we can do to reduce stigma is never call someone an HIV infected person. That is actually not at all what defines that individual. It is a person living with HIV. That is an example of person first language. And we never want to say, again, an injection drug user, but a person who injects drugs. So putting that person first and then the particular condition that they're living with along with other conditions. So again, not a user or a substance user, but a person with a substance use disorder. Not an alcoholic, but a person with alcohol use disorder. Person first language is really important to reduce stigma with any condition. And then we have to be aware as we're working in that patient-provider interaction that not only are we going to use person-first language, not only are we going to become culturally more aware of our differences and destigmatize the language of how you can get and not get HIV, but also think about the impacts of trauma for people living with HIV and HIV care. There is common in our patient population experiences of childhood trauma, such as physical, sexual, and emotional abuse and neglect, and mental illness or substance use in the family. This all contributes to the development of future substance use disorders in adulthood. And because of the development of future substance use disorders, that can, of course, lead to increased rates of HIV, other sexually transmitted diseases, not being engaged in care, increased viral load, reduced immune function, and accelerated decline. So all of that means that we also have to incorporate trauma-informed care into our interactions of people living with substance use. And what are the 6 guiding principles of trauma-informed care? Because there is a way to get trained in this and to think about safety first and how someone is feeling in that interaction. You as a provider being trustworthy and transparent, providing peer support in a trauma-informed care model, especially of those who have also experienced childhood trauma, using our collaborations and mutuality with substance use providers, with mental health providers, with psychiatrists, with those who can help us with housing, provide patients with empowerment and voice and choice, use patient-centered decision-making, and think about cultural and historical and gender issues in the context of the provision of care. The other thing we have to do is be sex positive in our communications about HIV transmission. An abstinence-based only approach has never worked, actually. It is really using kind of assessing your own comfort with discussing sexual risk, thinking about ways to stay safe from HIV within the context of ongoing sexual behavior. That would include PrEP, that would include clean needles, that would include condoms, and all of this is neutral, using inclusive terms, absolutely not making assumptions about gender or sexual orientation, using terms like partner, and watching your patient, ensuring that they feel comfortable as you're in a non-stigmatizing way providing sexual health information. So, in terms of how we can choose less risky sexual behaviors, think about condom use, think about oral sex or touching, taking medicines to prevent HIV. We have really effective oral and injectable PrEP options in 2024 to prevent HIV, and also counseling people on those who are living with HIV that if they take HIV medications and achieve undetectability in their viral load, that undetectability really equals untransmissibility. If you are virologically suppressed less than 200 copies per mil in your viral load, you cannot pass on that virus. And that is data from very large cohort studies, and we're really at a risk of zero. And then in the context of injecting drugs, using clean needles, not sharing equipment or syringes. So, what are some other healthcare provider strategies that we can use to improve rates of early HIV diagnosis? Because HIV testing and getting diagnosed is the first step in the HIV care continuum. So we have to recognize populations that could be at risk of HIV, which include people who inject drugs, those who are sexually active, MSM and bisexual men as having a little bit higher risk than heterosexuals with sexual partners at risk for HIV infection. And we have to recognize indicator conditions in those who are not considered at risk. And that includes we're essentially having sex in the heterosexual world with those who are at higher risk, STDs, being in group settings or other settings where there could be a higher risk for HIV infection. We have to be really alert to acute HIV infection accompanied by the seroconversion syndrome with fever and pharyngitis and rash and other symptoms of having an acute HIV, and address our own implicit biases of who's at risk or who we think is at risk, and then make testing really accessible. Really big push by the CDC for self-testing. So what do we do when usual care isn't working? We really need care models that can reach patients who are not well served by traditional healthcare systems. We have to meet individuals where they are, tailor to their acuity and the needs of clients, and be nimble and patient-centered. So what does that mean? What does that mean about being nimble, patient-centered, and meeting people where they are? That approach in how to enact care has a title at this point, which is called differentiated services delivery. And what that is a patient-centered approach that simplifies and adapts the intensity and frequency of interactions based on how the patient is doing and also on their needs and preferences. So you tailor services to patient needs, you efficiently deploy resources, and in the global context, that really has been employed by the World Health Organization to reduce burden on healthcare systems. For those who are doing well, who could take their HIV therapy, go to seeing them every 6 months or 1 year in the global health setting. In the US context, really intensifying services for those with complex needs, and for those who can take their pills every day and are doing well, de-intensify services and have them come in less often. So what does differentiated service delivery look like? It's really dividing between low intensity for those who are fine, who don't need that support, and high intensity services for patients who are unengaged, not virologically suppressed, where we need to provide more intensive support to help support them get that goal of virologic suppression. The first step in doing that is to really triage patients in terms of their acuity when you see them for the first time. Figure out by an acuity scale, what do they need? Where are they in terms of their social determinants? Where are they in terms of their housing status, mental health concerns, substance use disorder, and triage them into more or less intensity services. In terms of differentiated service delivery development, we really have to center the voices and lived experience of those most impacted by HIV when we engage people with HIV in our care. That means that we have to work with community-based organizations that can help with other determinants. We have to ensure that people living with HIV are part of our workforce and are part of our peer support and community models. We have to identify funding streams that will support DSD delivery and patch together a strategy for funding that allows out-of-clinic services also to be counted into our care paradigms. So what does low barrier care mean? This really is the idea that if you're homeless, if you're using substances, it is hard to just remember that appointment at 4 p.m. on a Tuesday. You really want a low barrier model of care where people can just walk into care with an integrated care team with whom they're familiar, provide incentives to coming into care, and having that multi-sector coordination, all of those services right there and then to bring it all together for low barrier care. I'll tell you about two programs where we've really put DSD in action here in the United States. One is the Max and Mode clinics up in Seattle. And this is really, the Max stands for Maximal Assistant Clinic, but it's really designed to engage patients with barriers to care. It's low threshold, can walk in anytime, combined with high intensity outreach to get people to come in, utilizes incentives and supports like food vouchers, snacks, bus passes, cell phones, cash to support patients coming in and being engaged. And the moderate needs clinic is bringing that down a bit, where they don't require that much with the max approach, but having some difficulty. So it's less intense services. We also have a program in San Francisco called the Ward 86 Pop-Up Program. And this was really based on the fact that those who are housed in San Francisco are more likely to be virologically suppressed than those who are living with homelessness or who experience unstable housing. And because of that, we wanted to engage this population who is living with homelessness and HIV. And we also did an analysis at Ward 86 where we saw that the more unstable your housing was, meaning living on the streets, the more likely you were not to be virologically suppressed. Whereas even living in a shelter or having transitional housing or having an SRO would be associated with more stable virologic suppression rates. And those who are experiencing homelessness are using the hospital, the ER, urgent cares, but they're not coming into private sessions. We also did some analyses before we started our pop-up program about what patients would want out of a homeless care program. And what they wanted was to see the same people. They definitely wanted incentives, but to see the same team, to have a relationship with that team. And so putting that all together, we came up with the HIV low barrier care philosophy and started the pop-up program. The pop-up model of care has drop-in access to comprehensive primary care, an integrated care team, incentivized care, and it's a low barrier philosophy. You can drop in any afternoon. It's the same team who sees you, the same social worker, the same nurse, the same pharmacist, the same case manager, a couple of rotating providers, but you know them. And anyone who's engaged in the pop-up program has to have unstable housing, has to have ongoing viremia, and we use all these high intensity services to try to work on virologic suppression rates. We actually have published our 12-month outcomes of the pop-up program, and things are going well. Of 112 persons who came in with virologic non-suppression and housing instability, 52% were street homeless, 100 full-on, 100% had substance use disorder, 70% had mental health diagnoses. But with all those intensive services through the pop-up program, we were able to get to a high degree of care engagement. And 59% had at least one 90-day gap in care. So we really worked on that patient population. And then in terms of virologic suppression rates, we're able to achieve 2/3 attaining suppression, at least at first. There was less suppression at that 12-month mark, and we're working on intensifying our services to those who are homeless and needing low barrier care in the pop-up program. So, how do we think about the care for those who are living with HIV and have substance use disorder? And in this section, we are going to get into long-acting antiretroviral therapy and the evidence for long-acting ART in those with substance use disorders and those with other barriers to taking oral ART. So, we've already discussed that substance use disorders are prevalent among our populations with HIV, that we should be non-judgmental when we address substance use and sexual risk, and that we should screen for additional mental health disorders in those with substance use disorder and HIV, and that anyone with a substance use disorder should be offered evidence-based pharmacotherapy for both opioid use disorder and alcohol use disorder and stimulant use disorder. Certainly, substance use is not a contraindication to ART. People who use substances can very effectively engage and take ART. So it's true that substance use will increase the likelihood of risk-taking behaviors and drug-drug interactions. So when we think about antiretroviral regimens for those living with substance use disorder, we have to think about simplifying, making this regimen as easy as possible, using single tablet regimens, using those with high barriers to resistance, like darunavir-based regimens, using those with low hepatotoxicity and those with alcohol use disorder, and a low potential for drug-drug interactions. It's also really important to think about this novel era that we're in. We are in an era where we can use long-acting injectables for the treatment of HIV. And why would it be particularly impactful to using long-acting injectables in those with substance use disorders? Because those with substance use disorders can have a hard time taking an oral pill every day. Adherence can be hard. We want to think about these novel strategies of using an injectable once a month or even preferably every 2 months, to think about a way for those with substance use disorders to sort of go about their way after they've gotten their injection and then come in for those regular injection intervals. And why have we even thought about using long actings in those with adherence challenges? Because long acting medications have been developed in other fields, like, for example, psychotic disorders, contraception, substance use disorders. Long acting has always been an idea that's out there to think about helping those with adherence challenges get treated without having to take a pill every day. So let's get into the data now of those who have why we would want to use long acting ART in this patient population with substance use disorders. When we talk about anyone with HIV, we have to remember that we're trying to start HIV therapy as soon as possible. Really rapidly starting ART therapy is now on the DHHS and the WHO guidelines for HIV management. We want to get ART on board right away, because what that does is really get people into patterns of drug taking, of medication taking, to stay on therapy, to rapidly use therapy. So when we think about choosing and our individualized therapy, we're going to get into long acting in a minute, but for those who are okay taking oral ART, think about baseline resistance. Definitely get genotypic resistance testing on diagnosis. Think about what are their barriers in terms of food interactions, other drug-drug interactions, getting access, and think about the barriers to resistance of that regimen. If a patient is not going to take a drug consistently, you absolutely want a regimen with a high genetic barrier to resistance. And think about carrying around the drug in a backpack. If there's housing instability, where can they store their drugs? Really get into a patient-centered plan for this. Now, the DHHS and IAS USA treatment guidelines in the United States both really focus on integrase inhibitors as first-line therapy for HIV drugs. And that would be either bictegravir, tafamtricitabine, or dolutegravir-based regimens. But the reason we want to talk about long-acting ART is at least one of the components of long-acting antiretroviral therapy is also an integrase inhibitor, and we have increasing data of the use of long-acting ART in adherence challenge populations. The whole point to use a long-acting regimen is we really want to optimize ART in both those who are virologically suppressed and those who aren't, and help overcome our adherence challenges. There are advantages to daily oral ART, and there are advantages and challenges to long-acting ART. The good thing about daily oral ART is it's self-administered. They don't have to come to the clinic to get an injection. It's non-invasive. You can go and get it at a pharmacy. But there are challenges. There are ongoing challenges to daily adherence to oral ART. Those include what we've already discussed: forgetting, substance use, housing instability, mental health disorders, stigma of having a medication and being in that shelter, and transportation difficulties, childcare difficulties. All of these are still making sure that we unfortunately do not have 100% virologic suppression rate in this country of those on oral ART, because these adherence challenges are real. The advantages of long-acting ART is you don't have to remember to take that pill every day. You can just come into the clinic at the interval required by the long-acting injectable, get that injection, and then go about your day and come back when the injection is next due. It really can reduce stigma in terms of having HIV medications on you in a shelter or in a home where you don't want people to know that you have HIV. But there is a challenge in the sense that you do have to use needles, can't get away from that with injectables, and that you do, as a clinic, need to make reminder calls to ensure that as close as possible that we get on-time injection every 8 weeks, if that's the interval that's required. I also want to remind you that there are medications for opiate use disorder, for alcohol use disorder, and for methamphetamine use disorder. And alcohol use disorder, I think, is undertreated in this country, but there are really oral medications that could be used, disulfiram, naltrexone, acamprosate, that are used in patients that use alcohol, and there are really no significant in contraindications with the use of antiretroviral therapy for any of these. We're not really giving antiretroviral oral solutions, which can contraindicate disulfiram. So don't worry about those indications. And there are no contraindications with the use of medications like buprenorphine and methadone that we use for opiate use disorder, or some of the more experimental medications like Effexor or naltrexone for methamphetamine use disorder. These are the medications that we use for opioid use disorder: buprenorphine, methadone, naltrexone. They all have pluses and minuses, including having to pick up that methadone every day for the methadone outpatient treatment programs. And buprenorphine can have concerns in the community about withdrawal, but if we do everything right, we can certainly minimize any risk of withdrawal. And naltrexone is now available as a depot formulation. And the only thing about these particular three medications for opioid use disorder is that there are some interactions of buprenorphine and methadone with antiretroviral drugs. They're not significant, and what I mean by that is we just have to be aware that methadone levels can decrease if we're using antiretrovirals, which are potent CYP3A4 inducers like efavirenz, and just be aware to increase our methadone. And that also, if we're using potent CYP3A4 inhibitors like ritonavir or cobicistat, to be aware that methadone levels can increase. So these are just steps to be aware of as we're designing our antiretroviral regimen. So let's go on to the use of long-acting antiretroviral regimens in those with adherence challenges. The only one that's available in combination treatment is cabotegravir and rilpivirine. It combines cabotegravir, which is an integrase inhibitor, with rilpivirine, which is an NNRTI, and it is indicated, or at least approved, going down to 35 kilograms or 12 years of age or older in this country. It was initially approved by the FDA in January of 2021, and it has to be given as an injection, basically usually in the gluteal muscle, every 8 weeks, or monthly, though we're increasingly going to the every 8 weeks formulation at a higher dose. There are 3 trials that examine cabotegravir and rilpivirine in those who are virologically suppressed. So these trials were the FLAIR study, and that actually studied cabotegravir and rilpivirine every 4 weeks in those who are treatment naive. But the drugs were not given directly to inject. Actually, it were patients who were in this trial who are naive. They first got put on dolutegravir, abacavir, and 3-TC, suppressed for at least 20 weeks, and then when they were suppressed, switched over to the long-acting injectable cabotegravir and rilpivirine. The FLAIR study has very low rates of confirmed virologic failure at 124 weeks, and there was some resistance of INSTIs that developed in the virologic failures. The ATLAS and ATLAS 2M study, the design of these were using cabotegravir and rilpivirine in those who were virologically suppressed in the regimens that they were already on. They were taking stable antiretroviral therapy, stabling virologically suppressed, and then switched over to the long-acting cabotegravir and rilpivirine. In ATLAS, it was every 4 weeks, and in ATLAS 2M, the cab-ril was given every 8 weeks at a higher dose. Again, low rates of confirmed virologic failure out to 152 weeks, though there is a potential for the development of resistance in those who virologically fail. And then finally, the SOLAR study was performed actually after the drugs were approved. FLAIR, ATLAS, and ATLAS 2M were the registrational trials to get to FDA approval. SOLAR was published after the drugs were already in the market, and this was looking at cabotegravir and rilpivirine every 8 weeks in those who had originally been on BIC, TAF, FTC, switched over to cabotegravir and rilpivirine, and found very high rates of confirmed virologic suppression with a switch to therapy, and also importantly, patient-centered outcomes that really reported satisfaction with the long-acting ART regimen. So that's the data in those who are virologically suppressed, doing fine, and that's what the FDA package insert says right now. Every HIV provider has been very interested in using long-acting injectables in those who have a hard time taking oral therapy every day. Those, again, who use substances, homelessness, have mental health disorders, because it's that patient population that's been the hardest to suppress. And in fact, about 10% of people living with HIV in this country hold 90% of the virus. All these overlapping concomitant challenges to adherence that we've discussed. And so we really want to think about long-acting ART in that patient population. Well, what's the data? What's the evidence that we can use long-acting ART in adherence challenged patient populations? One level of evidence comes from our clinic at Ward 86, which is our clinic that serves publicly insured patients in the city of San Francisco. We started offering long-acting Cabril very soon after these medications were approved, not just for those on the left-hand side of this slide that were in the trials, those who were virologically suppressed, but we also allowed in individuals who had adherence challenges, who were even viremic and could not take oral ART. We allowed them into our demonstration project to follow their outcomes on Cabril when they really couldn't take that oral ART because of all these challenges. We have already published the results of our first set of data in the Annals of Internal Medicine in July of 2023. And now I'm going to show you results that we just presented at CROI 2024 in Denver from March 3rd through 6th about the 48-week follow-up results of the patients who started in our demonstration project who were actively viremic when we started cabotegravir and rilpivirine. We had 59 people who were viremic, could not take oral ART, and we followed them out to 48 weeks. It's important to say that 61% of these individuals were using stimulants, 10% were using opioids, so a high rate of substance use disorder, and 52% were experiencing homelessness or unstable housing. And the results that we presented at CROI are shown here. Of those 59 individuals who were started on long-acting ART in the setting of viremia, 93% at 48 weeks were still virologically suppressed with a viral load of less than 50, and 95% were virologically suppressed with a viral load of less than 200. So really encouraging durable virologic suppression rates on those who started long-acting Cabril in the setting of viremia. We're not the only demonstration project or clinic that's been doing this. The OPERA cohort showed their data at ID Week in Boston in October of 2023. The OPERA cohort is an electronic medical records database that represents about 14% of people living with HIV in the US. And in the OPERA cohort, 176 individuals living with HIV had been started on long-acting ART with viremia. This study showed us what were their treatment outcomes after starting long-acting Cabril with viremia, and had similar findings to our study that 82% had achieved a virologic suppression rate of less than 50 at that 6-month mark or later on starting on long-acting ART, and 94% achieved virologic suppression if a viral load of less than 200 was used. So really encouraging durable outcomes from these demonstration projects on using long-acting Cabril in viremic individuals. There was also a very small study from the University of Mississippi, which was only 12 patients, lots of barriers to taking oral ART, and all 12 patients were offered Cabril in the setting of viremia, and all 12 patients virologically suppressed with no discontinuations in this small demonstration project. So what about data from randomized controlled studies? Well, we now have data that was presented at CROI 2024 about the use of long-acting Cabril in adherence challenge populations. This was the ECTG 5359 or Latitude study, and the design of this study is shown on this slide, but actually anyone who had adherence challenges was not first put on cabotegravir rilpivirine. Step 1 of the protocol for 24 weeks was to first get those individuals in the study suppressed on oral ART with conditional economic incentives. And then the step 2 of the study was to randomize to either staying on oral ART or switching over to long-acting cabotegravir and rilpivirine. And then step 3 was to go out to 52 weeks. This study actually had to be stopped early by the DSMB because of favorable outcomes, which I'll show you on the next slide, of the use of long-acting cab-ril in those with adherence challenges. I will make mention that even though everyone was supposed to be virologically suppressed on oral ART before going to step 2, 17% of patients who went to IM cab-ril were still actually viremic when they entered step 2 in that particular arm of the study, just because it was so hard to get patients virologically suppressed on oral ART. These are the results of the study that led the DSMB on February 12, 2024 to stop the study early, because there was an obvious difference, actually a superiority of long-acting injectable cabotegravir rilpivirine for those with adherence challenges versus oral ART. That's shown in that second panel, with those with virologic failure was higher in the standard of care oral ART arm at 25% than those on long-acting cab-ril at 7.2%. And in terms of treatment-related failure, still saw that superiority of long-acting ART to oral ART in those with adherence challenges. This is likely to change guidelines everywhere and has already changed the IAS USA treatment guidelines. Now, as of March 2024, ISA USA says that we should consider the use of long-acting injectable therapy for those who have viremia and those who have adherence challenges, because if you can't take oral ART, it's much worse to be off ART than certainly providing these extensive, providing the long-acting ART. And those who can't stay on oral ART are at risk both for transmitting the virus and certainly of a high risk of HIV disease progression. So IAS USA guidelines have already changed, still looking to the FDA and the DHHS guidelines to make changes at some point based on the results of this important study. And then I had mentioned the SOLAR trial before when I summarized the data of the use of long-acting cab-ril in virologically suppressed patients. But the reason I wanted to show this slide is that there was really favorable patient preference outcomes for those who got switched over to long-acting. Actually, 47% of participants in the SOLAR trial said that they had either internal stigma, that taking a pill made them feel they had HIV, or external stigma, that they didn't want people to know they had HIV by taking a pill. And there was such patient improvement in patient-reported outcomes. They really preferred the long-acting cab-ril, especially in the context of internal or external stigma. And this has been shown across the board. There's really a high preference for long-acting injectables, especially in the context of stigma. So that's the data for long-acting cab-ril in adherence challenge populations. I think it's extremely favorable. And what's an adherence challenge population? Of course, it's those who use those substances. And all of those studies had included patients who use substances in the study design. So I think we have to be shifting our thinking of thinking about long-acting ART in those who use substances. I want to just give the data on one other long-acting ART medication that's available and approved in the US, which is lenacapavir. This was approved in December of 2022, but the data for lenacapavir is much more limited than what we have for cabotegravir and rilpivirine to date. This has been studied essentially in multi-drug resistant virus. And the reason that it would be useful for MDR HIV is because this is a first-in-class medication, a new class of medications, which is called a capsid inhibitor. Lenacapavir is given every 6 months or 26 weeks as a subcutaneous administration after first having 2 oral loading doses. And what was the study that examined the use of sub-Q lenacapavir in multi-drug resistant HIV that led to its approval? Well, this was called the Capella study. And the participants in the Capella study were all very multi-drug experienced. They had resistance to at least 2 agents from 3 of the 4 main ARV classes, and were randomized to an oral background regimen that was optimized for them, or starting on lenacapavir with that optimized background regimen. And the first set of results of this study was published in the New England Journal at 26 weeks. And then we have follow-up data for the Capella study that was published in HIV Lancet, Lancet HIV at 52 weeks, and we have follow-up data from the CROI 2024 meeting at 104 weeks. Virologic outcomes are much better if you have lenacapavir versus that optimized background regimen, and this is because of this improvement. This was approved in December 2022 for MDR HIV. I also mentioned lenacapavir here because some of us have been using it off-label with cabotegravir in those with NNRTI resistance, and we've published a case series in OFID just this month, April 2024, about the use of lenacapavir with cabotegravir in patients with NNRTI resistance. The important thing about Capella is that you do have to have some regimen in the background that works, and patients did better with more drugs in the regimen that also supported and bolstered lenacapavir to work, including other drugs that we use for MDR HIV, such as ibalizumab or fostemsavir. This was the data that was shown at CROI 2024, which is now the final data set from the Capella study out to 104 weeks. It's very important to note that there were 72 participants in the Capella study, and 14 out of 72 had initially shown some evidence of failure, but with intensification of the adherence support around taking the oral regimen with the Capella subcutaneous regimen, actually only 2 out of 72 ultimately failed. And that is the final results of the study. 70 over 72 were virologically suppressed in the Capella study despite having MDR HIV. So really important drug for MDR HIV, and our third drug available for long-acting administration. There are going to be other long-acting medications that come out, and we're entering a very exciting phase of going into the use of long-acting medications, which can be so helpful for those with adherence challenges. This was a phase 2 study that was presented at CROI 2024 in Denver that looked at a combination of islatravir, which is a new NRTTI, and lenacapavir given once weekly. These were participants who are virologically suppressed, and switching over to that once weekly administration of islatravir and lenacapavir given as an oral pill once weekly showed high rates of maintenance of virologic suppression in the islatravir lenacapavir arm. So this drug combination is entering phase 3 trials. There are other HIV therapeutics in the pipeline that are coming that are long-acting, besides islatravir that we already mentioned, which will not be used for PrEP, but only in the treatment regimen. We also have to look ahead to other medications such as investigational new NNRTIs and investigational new INSTIs, and we also have broadly neutralizing antibodies that are used with lenacapavir every 6 months in those living with HIV.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/VCQ860. This activity is supported by an educational grant from Gilead Sciences Incorporated.